Right, yeah, so I'd just like to acknowledge country. I acknowledge that I am recording this meeting today from the lands of the Warramagal people of the Darug Nation. I also acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this meeting. Just a reminder to everybody, and I did send it out with the invite, that today's meeting will be uploaded to the AIHI YouTube channel. And if you're not comfortable with this being featured in this, can you just please let us know? So I haven't had anybody say they didn't, and Alana has very kindly agreed to share the information. So I'd like to introduce, no, I'm not presenting today, actually, I'm just get rid of that word. So I just want to introduce Alana Delaforce, who's presenting today from Queensland. Is that right? Yes.
Yep.
Yep. And Alana is currently works as a safety and quality manager and a sessional university lecturer, and has research funding through the Mater Hospital for this in Brisbane for this research. She's almost completing writing up stage of her PhD, which she took to understand the consequences of not optimizing, conserving and preserving a patient's blood. And the project also sought to understand how to implement recommendations that facilitate evidence-based blood management. And Alana has a background as a peri-operative nurse working in neurosurgical theatres as a scrub scout. So welcome and thank you ever so much, Alana, for joining us today at ISIG. So over to you.
Thanks, Karen, and thanks for having me. So I basically going to end up summarising what's become my entire PhD project. And so essentially, I have used multiple frameworks to diagnose and address implementation problems. And that's in the context of evidence-based blood management. So I will give a little bit of information about what the blood management recommendations are and a little bit about each framework. I won't go into too much detail because I'm assuming most people are probably aware of some of the frameworks that I'll talk about. But if anyone has any questions at the end, I'm happy to answer them. So this whole project came into being from an observation I made as a scrub scout nurse. So in clinical practice, we did lots of big spinal surgeries and patients would lose a lot of blood. But on this particular day, we were doing something relatively minor, and we had a young, fit 57-kilo lady, so quite petite, having a routine 2-level laminectomy. So that's where we just take a bit of bone out of the spinal processes. Patients don't normally lose too much blood. But in this particular occasion, she lost about 1.6 litres of blood. And in fact, we thought that we'd forgotten to change the suction tubing from the previous case, which collects all the blood, because it was so significant. But when we calculated at the rate it continued to go, that's what happened for her. She lost all of that blood, and that's around half of the average amount that we have in our body. So you can imagine that's pretty significant. And the particular surgeon in this case was not always the greatest with their hemostasis. And so I just started wondering about what the implications would be for this patient. Like, what are their outcomes going to be if they've lost all that blood? And what sort of preparation did we have for them? And what happens when they're exposed to transfusion, which is sort of like an organ donation, really. And so I started doing some reading, and I saw that blood transfusions come with quite significant increased risks. So patients are 1.6 times more likely to have an infection as a result of having a transfusion. There are quite an increased risk of coagulopathy. So there was a 750,000 patient registry study done in the US, and they found that with one bag of blood, they had a 2.2 times risk of having a VTE, and that went up to 4.5 times if they had 3 or more bags of blood. They also stay about a day longer in hospital than patients who don't get a transfusion. They have immunomodulation, where they're picking up the antibodies of other patients' blood, And then they were also at a risk of having an adverse transfusion reaction. So that could just be something minor, like getting a bit febrile, or they could get circulatory overload. And then at the worst case scenario is getting an incompatible type as a result of administrative areas. So we know that there's all these risks. How do we help make sure that we're not unnecessarily exposing patients, like the lady I mentioned, to those risks? And there are ultimately three main things that we can do to achieve that. And so they're described as pillars in blood management literature. So the first pillar is about identifying and treating any preoperative anemia. The second one is using intraoperative techniques to minimize the loss. And then the third pillar is all about assisting patients to tolerate any anemia that they have postoperatively, rather than gung-ho going for a blood transfusion. So knowing all of this and seeing in practice that it wasn't happening, I decided to embark on a project to try and improve practice. And so the overarching framework that I used was the knowledge to action framework. And so I'm just going to step through each phase, that what happened at each phase, and what we've ended up, where we've ended up, and how everything's gone. So phase one, as we know, is sort of determining the no-do gap. So in the creation cycle here, we've already got the patient blood management guidelines. They're the result of a systematic review, and it's been synthesized into that product or tool. And so now I want to know why it's not being used. And the way that I found that out was by having a look at some benchmarking data. So we were transfusing at about double the rate of other hospitals, according to our benchmarking data in the orthopedic and gastrointestinal population. And to understand that a bit better, we did 3 audits. So the first one was quite small, and we only looked at patients who had those transfusions from that benchmarking data. So I guess we were looking at the characteristics of people who were getting the blood. Why are they getting it? Why are we different? And is it appropriate? And what we found was that 42% of those patients, and I know these are small numbers, but I mean, in the great, you'll see a bit later on that these trends sort of carry through. 42% of these patients were anemic preoperatively, and only 21% of those had iron studies. So the implication of iron studies is basically to help the clinician understand whether or not the patient has anemia on itself, which is a suboptimal hemoglobin level. So for men, that's 130 grams a deciliter, and for women, that's 120 grams a deciliter or less. We're considered to have anemia, but we also want to know if that's because of an iron deficiency, because then we can correct things. If they've got an underlying iron deficiency there and we correct that, they're more likely to have an increased hemoglobin by the time they hit surgery, so that when they do lose all that blood, it's sort of the body can compensate because they've got the reserve iron stores there. So the next thing we wanted to do was look more broadly at all of our patients having those types of surgery. And so in this one, we included 607 patients. And so this was basically 6 months of every patient across public and private who had major orthopedic surgery. And so 14.6% of those patients were anemic preoperatively, and only 5% of those received treatment. So we're starting to really uncover here exactly what the trend is. And you'll notice if we went back to those first 3 pillars, that this is all really painting a picture that the main problem we need to fix at this present time was that pillar 1. How do we optimize our patients preoperatively? The third and final audit that we did had 559 patients in it, and only 5.2% of those patients had the recommended tests at least 1 week before surgery. So based on all of this, we decided to try and come up with a pathway and an intervention that would basically help improve and support practice. So moving on to phase 2 now, which is adapting knowledge to local context. And so this probably isn't reported as much as I would have liked in my publications. It's a really good discussion for my thesis, I guess. We went through a process of developing a preoperative anemia screening and treatment procedure in consultation with the multidisciplinary team. So we're really conscious to make sure we engage with clinicians on the floor when we were developing it. We didn't just come up with the National Blood Authority recommendations and then just dump it in and go, oh, here you go, thank you, you can do this now and then see you later. we really made sure we engaged with everyone and came up with something that's really quite tailored. And in fact, we've got different pathways depending on whether you're a public or a private patient. So there's one screening tool, but then, you know, it's tailored between which hospital that you're going to, because MARTA has a complex model of care. They take some public patients and also have private care delivery. So the way in which the politics and the cohort of practitioners is very different between those two. And the other thing we did was to develop a procedure list tailored to a local consensus over which procedures resulted in greatest blood loss. So the National Blood Authority recommends that if you're going to lose 500 mils or more, that you should have this preoperative anemia and iron optimization. But there was just a lack of consensus about which procedures that would actually be. So for example, in the gynecology cohort, they did not want to include non-cancer surgery for abdominal hysterectomies. It was only in the gynae-oncology group where that was happening that we would include them in this pathway. So little things like that, engaging with the specialties, making sure they've got something that they really agree with and that they're not feeling like they're doing testing for no reason. So that was phase 2. Phase 3, we wanted to assess the barriers to that pathway use. So I used the CIFA, which is it has the 5 domains and then the 42 constructs that are thought to influence implementation. And the way that I used that was basically to do semi-structured interviews with a maximum variation sample to understand what the barriers were. And so I took that information and I coded it. I'll go into a bit more detail of that down the track. So we use CIFA, and then we mapped those barriers to the ERIC framework. And I'm not sure if you're all familiar with this, but there's a CIFA org website that is really handy and really user-friendly, and it has all of the constructs, and then it has the ERIC implementation strategy matching tool. And if you go to this website, you can bring up the tool and basically input all your barriers, and it'll map them across to recommended strategies that was developed by consensus as to what should have a high impact on improving your implementation. And then we also use the act-to-action context target time, which is an extension of the target action context time framework. So previously didn't really consider the person delivering the intervention, only those receiving it. And this second iteration more overtly considers who needs to do what differently. So it considers that clinician as well as perhaps the patient that is receiving the intervention. And so, sorry, it's a bit blurry. This is my summary of my methods. I've just pulled this from an abstract of my paper. And I'm going to go ahead and explain in a bit more detail why I chose to use all of those frameworks. So what I found when we did the content analysis and I coded all the interviews to CIFA myself, I then sent a pilot sample to my supervisors to check for agreement. That was quite good. It was about 80 or 90%. So then I went ahead and coded all the rest and I sent it to my co-authors just for another check over. But there were all of these, there were about 37 barriers, and practically, you know, developing an implementation plan to address 37 barriers would be insane. So I thought, how are we going to prioritize these? And so that's where the ACT framework came in. And so I developed a table, which I'll show you on the next slide, where I summarized the barriers by ACT category. So say with a pre-admission nurse, I worked out what their most common barriers, you know, if they had 5 or more mentions, then they would get included as a barrier. And then I sent those barriers back to the participants for checking to say, look, based on the interviews, how I coded them, these are the key barriers I found for you. Do you agree with them? And everyone said yes, which was great. And so then I went ahead and mapped those to the ERIC strategies. And so I'm just going to bring up this table to show you. This is the page that I wanted. Where's the PDF? Oh, no, that's not it. No, sorry. I've lost my way. I'm glad I copied this. I'll come back. I opened this in preparation. Here we are. So here's the table, just to give a bit of a visual guide to what I'm speaking of. So here we've got the actor, say the patient, the action.
Alana, you need to share that with us because it's just got your slide.
Got you.
Yeah, thanks.
Yep, sure. Is that coming up now?
Yeah. Yes, right. Thank you. Thanks.
So we had the actor, the patient, the action. We wanted them to comply with blood tests promptly, and then the barriers we had identified to that were access to knowledge and information and patient needs and resources. So to overcome that, we were wanting to ensure that patients were adequately educated before they, at the time of their pre-admission, to know that they need to have the tests. And we also developed some patient resources in consultation with the patients and their feedback. The next one was anaesthetists. So we want them to initiate preventative treatment through referral or using the treatment strategies of IV iron. And then again, there were their barriers, knowledge and beliefs and executing it. We didn't have any strong recommendations for that. So in this table, I guess this, interestingly, if I can make a segue, I'm thinking of our last presentation when we were talking about having a purist approach to things and the importance of using things and building on them. And I guess it's interesting in this case that there are areas where the ERIC didn't particularly provide an answer for everything. So I think that'll be a really interesting point of discussion in the paper about the impact of these potentially. And hopefully that'll help increase our knowledge about the utility of that framework. I won't go through all of those, but that's how I ended up coming up with my plan, basically. Instead of having all those 37 barriers, I condensed them down and found some really tight recommendations to inform our improvement plan. So I'll go back to the presentation now. I knew this would happen. Stop sharing. Yes, there we go. Great. So that was how we used phase 3 and phase 4. We kind of combined that together in that section of the study by assessing the barriers and then selecting, tailoring the strategies that we wanted to use for the intervention. Now I've lost my, there we go. So phase 5 is about monitoring knowledge use, so the compliance with the pathway, and phase 6 evaluating the outcomes. And so for the study that I'm just wrapping up now, we're writing up and doing our final analyses. We looked at clinical cost and implementation outcomes, so as well. So this is just a protocol that's available if you're interested. We looked at provider outcomes, so compliance with ordering the tests and providing appropriate treatment. We looked at the patient outcomes, so anemia or iron deficiency on the day of surgery and whether or not they had a blood transfusion pre-post. We also are looking at the health service cost. And then finally, for our implementation outcomes, we've looked at acceptability, appropriateness, and feasibility. And so we use the Wiener psychometric tool in order to do that using a survey. And so preliminary results are pretty positive. So we've reduced the, I can see a typo there, sorry. We've reduced the proportion of patients anemic on the day of surgery. We've massively improved compliance with testing and treatment, although there's been a heavier improvement in the ordering of tests and less of an improvement in treatment. And interestingly, there's a big patient component there that I think in hindsight, we probably should have done a bit more engagement with, both the clinicians to make sure that they are really educating the patient on having their tests done, and also making sure that we're really linking back in with the clinicians constantly about making sure that they're getting their treatment appropriately. When they've followed the pathway compliant fully, we've noted that there's been a reduced blood transfusion. We haven't looked at the cost yet. I'm still waiting for some statistical analysis to come back. But in terms of implementation outcomes, users found the pathway acceptable, feasible, and appropriate, but some barriers were not fully overcome. So I did ask a few questions in the survey that related to the barriers, because I thought it's good to use the standardized measures, but I also really wanted to know if we had overcome the barriers that we thought we had. And so one of the things that came out of that, which is not surprising based on the other results, was that the patients, that the clinicians didn't really feel the patients fully understood why they needed to have the test or the treatment done. And so that would be something that I would look at modifying and refining, and in a future iteration to improve the implementation of it. And so then phase 7 will be about sustained knowledge use. So that would be me using the lessons I've learned to adapt, modify, and improve the intervention and delivery. And then thinking about how we can change improve the patient's compliance. So, because you can lead a horse to water, but you can't make it drink. And I guess that's what our implementation science is all about, right? So I was thinking so heavily about getting the clinicians to change their behavior that I probably should have spent a bit more time focusing on that patient aspect, because I just didn't expect them to not understand that they needed to have it done. And then there's other things that came up anecdotally, like convenience. Some of them just didn't have the time. They had to go straight away after their appointment instead of walking upstairs to get their test done. Or sometimes we had outreach patients up north, and we couldn't bring them to our own IVI and infusion centre. And so that created another barrier. So that was some interesting things that came out of the study. And then also it would be really good to make the interventionist person dependent, I think. So one of the things I failed to mention earlier was that I acted as like a preoperative anemia coordinator. So I would download a list of all the patients who had had a pre-admission appointment and filter out who was having an eligible surgery, and then check to see if all their tests were ordered, which most of the time they were. And then when they weren't, I'd email clinicians going, oh, hey, just wondering why you didn't get a chance to order these. Are you getting pressure from a doctor not to do it? Or, just curious. And most of the time people had just forgotten to do it. And then also seeing if the clinicians had ordered appropriate treatment if it was required. And so then I'd send them a little email reminder to say, can you please order IVI for this particular patient? But it would be good if some of that could be more automated, so it's not relying on a human. And I fear that this probably won't come through particularly cost effective, and that's something that would need to be done in order to make it more viable going on into the future. So that's a broad summary of my experience in implementing something and using frameworks practically, and some of the challenges that I had with that. Yeah, that's it. I'm happy to answer any questions if anyone has them.
Thank you very much, Alana. That was very interesting. Yeah, I'm sure there are some, well, there's a nice little clapping of hands by Steph. I can't see everybody, so I could probably bring everybody in. But is there anybody would like to ask a question? Sorry, my mouse is there. Can you just unmute yourself if you've got a question? Can you stop the share screen maybe? Yeah. There we go. That's it. My mouse. Sorry, no, I've got a problem with my mouse. It doesn't move. So has there anybody got any questions there that they'd like to ask?
I'll ask a question, Karen. Yeah. Alana, I'm interested that you've used the Weiner AIM, IAM and FIM. I'm just wondering how that went and whether you felt you got useful information or any feedback from the staff about, did you find it useful and did they object to using it?
No, people filled out the survey, surprisingly, to be honest. Myself, if I had to do one of those surveys, I kind of go, oh, really? Come on. Truthfully, I'm being candid here, and I thought that might have been the case because they are a bit repetitive, and I can see why participants would feel like they were answering the same question, and I guess that's part of survey design methodology. But people did fill it out, and I did get useful feedback from it. And in the end, the manuscript's probably only going to have a paragraph of information saying people agreed or completely agreed that it was acceptable, agreed or completely agreed it was feasible. And then the one thing that I found was nice, they loved the preoperative anemia coordinator. They went to the effort of making a comment, because I had the barrier questions as well, and then I had a free text comment box, and some people said that they liked having the anemia coordinator to remind them if they'd missed out on doing the tests. So that was nice feedback. But yeah, it's a good point you raise. Have you used it?
We're just at the point of using it with some patients, and they've actually found it quite frustrating, the feedback we've got from them. I think, as you say, because the questions are quite repetitive, and that was my thoughts when I thought, and it's validated and everything, so you think, oh, you obviously have to ask the questions as they are, but we did put in a comments box as well, and I think that I would feel it would almost be a wasted opportunity if you didn't sort of ask them to expand a little bit on why they've said it's acceptable or whatever. So we haven't really got much data yet. I think we've got about 11 patients who've used it, but so quite early on.
Thank you. Okay, I was just, if I could just butt in and ask a question. Oh, Peter, you can ask a question. I'll butt in later.
You butt in first.
Oh, well, I was just interested in what you said, Alana, about the outreach patients who, you can't access to get the IV iron infusion. Is that because that, I can imagine in Queensland, that's a big issue. People are not going to come just to the, so is that something that you think would be, is there opportunities on how to improve that?
Yeah, the clinicians can ask the GP to refer their patients to a GP. More and more GP clinics are doing iron infusion.
All right. Yeah,
it's a very controversial treatment, because if the iron extravasates, it leaves permanent skin staining on the patient. So if the cannula is done properly and it's all running fine, then it's all hunky dory. But that's why there's been, I think, trepidation from GP clinics to sort of take up the opportunity to give it, is because there's that risk associated with it. But it is becoming more common. So yes, I agree. That would be something that I think clinicians would need more education on. And in the public sector, which I concentrated this first part of the study on, the residents are always rotating through. So that was one of the issues I had, was that, every time a new group comes through, you've got to kind of pounce on them friendly and go, hey, we've got this pathway, you need to follow it.
Yeah.
So outreach is definitely an issue. I'm hoping that as more GP clinics get on board with doing the treatment, that it will be, something that patients can access more easily when they're in those remote areas.
Yeah. Okay, thank you. Peter?
Thanks, Alana. That was great. And I got that real sense of this all started from a real problem on the ground that you were working in. And, I think that's fantastic that you've taken this pathway through personally and professionally and, with the system. So that's, congratulations to you for doing that. My question is, when you're using you mentioned the CIFA framework and developing up the semi-structured interviews, did you use the framework to develop the semi-structured interviews, or did you use the framework to do a post hoc, classification of what came out of the barriers for the interviews, or a bit of both?
A bit of both, actually. So what I did to help myself as a novice interviewer, I had a whole list of questions, and I used the CIFA.org website to help develop those. So I had a whole range of questions that I might ask according to each domain, but I didn't let that restrict me in the interview. So if the participant said something of interest, then I'd go off on a tangent with them about that. So it kind of loosely guided it to give me some ideas about questions that I should ask. And then it was more stringently adhered to during the coding process. And
was that helpful for you as a person who wasn't that familiar with that process? Any comments about its usefulness?
I think anytime you're coding to a predetermined framework, you're always going to have instances where you're like, oh, this doesn't really fit anything like 100%.
Yeah.
And there are those instances where you've got some barriers that are not really in that framework, and that you'd like to address separately. I know what you're getting at, and I agree with you. It's not the be all end all. I think it does leave room for error potentially, or where you might miss something. So yeah, that's how I use them. But I don't know what the answer is moving forward to try and enhance that. I guess it's trying to, as I said, all of us, whenever we've used these, have a look at what was missed and then report that as well. But sometimes that doesn't make the manuscript, right? You've got to keep it really tight and
it's kind of the 80-20 rule for me, isn't it? That 80% kind of fit quite well, and there's another 20% that don't fit very well. But I think there's a huge amount of usefulness in understanding what the bits don't fit. So, as well. So, thanks.
Yeah, thank you. Thanks. Very interesting. Mila, I see you've got your hand up. I hope I've pronounced your name correctly. So
you have. No, it's all good. My first time joining the group, so very entertaining to listen to the presentation. Alana, well done. I'm a fellow Queenslander, so I have 2 questions for you. Hopefully they're big questions, so don't feel bad if you can't answer them. The first one is around what you actually did in terms of research. So I was thinking around your presentation, you talk about the preoperative being the point where you prompt the testing, and I was thinking, is a week enough to increase the patient's condition prior to surgery, and whether you've considered pushing that framework or that pathway you developed further up the pipeline and working with, I don't know, the PHNs, so that they can distribute it locally to the GPs, so that because the low blood levels are connected to perhaps to the condition or not connected to it. But when we diagnose the condition, is that the point we should be screening the patients for any other comorbidities or low iron levels, so that when they are due to have the surgery, they're already prepared and ready to go. And there's a whole lot of issues. The private, you can easily reschedule the surgery. The public, there's probably a 3-month wait just for IV infusion. So, that creates huge backlogs. And I think probably, I don't know if there's a question in you, but I just wondered what were your thinking process along the lines there?
You have hit exactly one of my biggest struggles in the beginning of all of this. When I came into, I was very idealistic, and I had the same sort of view. I thought, we just need to get the GPs to start doing this screening. But there's no incentive for them to do that. And there was a big squabble over the doctors at the coalface, the pre-admissions team, perioperative medicine team, saying, oh, well, who's got the governance over the testing then? If we do the test and then we have a finding about it, and then we've got to go back to the GP, who's that going to sit with? And initially, I just ended up moving away from it because it just seemed like it was not going to work in our context at all. Anecdotally, I lobbied the Queensland Health because there are a number of blood tests that are considered essential information for referral. And so they have agreed, remarkably, to include iron studies for certain major referral pathways now. So I think perhaps it would be interesting in the evaluation phase to go back and see how much of this testing will now or screening will now be done in the GP arena. As you say, yes, I agree with you. This 1 week is definitely not enough. It's definitely not ideal. We need to be looking at 6 weeks at least to correct IV iron anemia properly with IV iron. It does have some benefit, a week and ultra short-term therapy. But yeah, definitely it needs to be looked more long-term. So I would be interested to see, with the change of those referral pathways, how that has an impact on the pathway as we have implemented it. And if we do see the GP taking on some more responsibility.
Yeah, because I think that will be such a significant finding of your PhD work, that you actually can demonstrate that you've impacted policy. And if, research is your future career, that will be very significant. Thank you. My other question is in terms of the different frameworks that you used. And one of the things that I often struggle with clinicians is that implementation science is very rich in multitude of frameworks and models. And the struggle is we don't know which one to use and when, let alone combine 3 or 4 in one study over a period of time. So are you able to share a little bit around your experience of how you went, navigate that, I guess, that whole landscape? And because it's really hard trying to introduce, they're very useful, if we learn to use them and apply them and sometimes combine them, but it's really, really hard to do in practice.
Yeah, I actually had a very painful lesson for this. And it goes right back to when I did a systematic review on what are the barriers and facilitators to PBM, you know, a lovely stock standard type thing you see now in the literature. And originally I had chosen the theoretical domains framework to code all of the data in that review. And I coded the whole lot, and the whole way through I was just niggling at myself going, this isn't fitting for me. I'm missing way too much here. And my feeling is that the TDF is really good for, say, so this is an example of how I got to where I did. You could pick any number of frameworks really, but I started out with a TDF and I really felt that's good for individual level barriers. But environmental really lumps in way too many things. And so I ended up recoding everything according to CIFA, and I felt much more comfortable after I had done that. And I think the trick, as you say, with implementation science is there's no right or wrong answer. You've kind of just got to pick what you feel is going to, I mean, as a researcher, particularly for qualitative stuff, you do get a sense of what the barriers are going to be. And you can probably pick a framework from that perspective. But yeah, I just feel like the CIFA captures the external influences, you know, the governmental policy, as we've just discussed, you know, the GPs, and then it also looks at the intervention, the individuals. It just all really came to, and the process, and so that's why I picked it in the end. I just felt that it offered more constructs that would potentially influence this problem.
Well, that's fair. Has anybody got anything to add to that discussion there about the frameworks? I think we've all been challenged with that at times.
I think the conversation earlier with, hi, Mitch, I was just in the background eating my lunch, that Peter brought up and that Alana expanded on around finding that, you know, you don't necessarily hit the nail every time with every framework, as in, like, there were obviously, I think you said there were ERIC strategies. Well, there were things that weren't on the ERIC strategy list that you thought were strategies, like around execution. And I think it comes back to the not always necessarily just rigidly following a framework or a theory, but thinking about why we're using it and then engaging in that theorizing process. So basically we're using it to try and come up with an intervention. And if there's an intervention missing from that theory or framework, then we need to continue building on that. And I know the CIFA, there's like a new edition of the CIFA coming out, which I found out last week on a call with Steph, with someone else. So, you know, obviously even the people who developed something as comprehensive as the CIFA have kind of re-looked at it and thought, okay, things need tweaking, things need changing. I know the Paris framework, they've also changed that to the Paris framework. So, you know, these things are constantly evolving. So that was not a question at all, just a rant to the group.
That's exciting information about the revised CIFA, that, because I'm a big fan of it, obviously. Do you have any timeline on when that's coming out?
No, it was an offhand comment from a colleague who knows the people working on it. I imagine it'll be early next year.
Yeah.
They're doing the work now.
Has anybody else had experiences about, you know, like Alana, changing frameworks or coming across some of those situations? No, you've all kept on the same one that you've decided on.
I would say definitely not. I have exactly the same problem. I always seem to think I don't know which framework I'm supposed to be using, and often have doubts halfway through. But I was just wondering, I mean, it's just a comment, but maybe the TDF would have been fine if right from the start you were focused only on addressing things that are happening at the clinician level.
Yeah.
I mean, and I suppose you came out with 37 different places that you could sort of intervene. So I suppose it's difficult to know, isn't it? You almost have to go through that big picture CIFA thing and then maybe drill down at the TDF level, if you decide actually the best place to intervene is the clinician or the patient or something. But I suppose that perhaps there's merits in doing it either way and then doing it again. I don't know.
Yes, no, you're right. That's a good point that you raised. It'll probably be very interesting to then go along with the theoretical domains framework and drill down onto the problem areas that I've identified that's still not quite right. Yeah, I agree.
Yeah, it's really good how some of these frameworks and process models can all interlink and really help with that getting that information. I think it's some great examples of that. That's and I just wanted to ask a question about the target action context time framework.
Mm-hmm.
So I'm not aware of that one. So that's something, that's a new thing. So how did you use that? I know you brought the table up, and was that?
Yeah, so I think I was just doing some reading about, I'd wanted to go back to the real, core theory. And so I came across the ACT paper, which builds upon the TACT framework. And that was combining the theory of planned behavior and theory of reasoned action originally. But it really focused on who was getting the intervention and not necessarily who was delivering it.
Right.
And because I needed to try and think about both conceptually, the ACT worked better for me that way. And I also wanted something rigorous to support why I chose to conceptualize things the way that I did. Like, I knew I wanted to prioritize the barriers, but I thought I need to find something to back up why I want to do this. So that was another reason why I brought it in, and it ended up being really helpful in the end to, I think in a first round implementation, let's try and get the biggest impact we can across the most stakeholders. That's why it was really helpful to me. And then as you say, if we then look more at the individual level later on in further research and assessment, it'll probably be more helpful. Have I gone off? Did I answer your question?
Yeah.
Okay.
Can I jump in with a
Yeah.
question, thought, something like that? I think it's really, I think we all have these challenges, don't we, about identifying theories and frameworks that we want to be using in different circumstances, and how pure to be in how it is that we're applying them, and what's going to be the best to be using at one time or another. And it's a beautiful idea that we can use one, and if it doesn't work, then we'll use another one. But of course, that takes a lot of time and resources to do that. And not many of us have really got the time that we can go, oh, well, I'll shift everything over into my third framework for this particular project, kind of thing. Oh, just one of the things that I was just thinking is around, and I was just thinking about you saying about using the TDF, and then that beautiful example of using the ACT framework, was I think a lot of it is really about being very clear about what it is that we want to achieve. So if you can be really, really clear with your initial target behavior in the first place, and you know what behavior it is that you want to be changing, then maybe the TDF can be useful in that circumstance. Sometimes we can't be that clear sort of early on, so maybe that's not the one that's most helpful at that point, because it's unlikely that we're going to be able to come down to some individual behavior at that point. And that might be when we do want to be looking at something a little broader. And the ACT framework can be really nice to help with some of that, can't it? And I really liked your that difference between the, sort of who's having the intervention done unto them, and who's the one who's delivering it, kind of thing, because we don't always think about that, do we? And so on that note, I was really interested in the consumer side of things, and I was interested in what are your thoughts about how you're going to engage them in the future. And I'm merrily assuming a nice postdoc here and a beautiful area of research to be looking at. So just wondered if you had any thoughts along that line.
It was interesting. I did develop, so I interviewed patients about this and to get their barriers, and I also developed some patient information in consultation with them. But I ended up getting stymied with my patient information because the organisation just put a moratorium on doing any more information at that time. Hospitals can be very fickle. They just decided, we've lost control of this. We want to have, you know, a very specific way that we develop our information and what's going out there. And so I'd gone through all this process and then that got stopped. So I definitely think that that probably hindered our implementation efforts a little bit. And that was something that was really outside of my control and will be for discussion in my paper. But in order to improve that engagement, I think that we would need to maybe do some more coaching with the pre-admission nurses to make sure that they are really, you know, educating their patients on why they need to have their tests done, because that was the other issue. Some of them don't go and get their tests done in a timely manner. We were ordering them. Compliance was great. It was 85 to 90% post, up from like 10, 15%, like a huge increase in compliance. But then the patients don't necessarily go and get the tests until maybe a couple of weeks before they're having a surgery. And by that time, as Mila said earlier, you know, it's really too late to be doing anything for them. So I think coaching is something I would do for the pre-admission nurses, and that could involve, you know, using multimodal resources. So maybe having a face-to-face educational meeting, and then maybe having a video available. And again, pushing that patient information resource to come through so that they've got a guide when they're talking to the patients, and then they can take something away with them. So there's some of the things I'd probably think about doing in the second iteration.
I was very interested because when you put up that's, you know, sort of that screenshot of your of the ACT framework that you did, and there was something about patients and sort of the solutions was going to be very much around education. Do you think it's that the patients don't know, or is it just, do you think it's more around, and this might be a really good TDF analysis type area to be looking at, or do you think it's actually they don't really realise how important it is for them to getting this done?
I think
so. Do you need to shift sort of,
when I went
the intervention?
When I went and interviewed the patients initially, I said, "Oh, did your doctor talk to you, or anyone talk to you about anemia? Do you know what it is?" They had, one had no idea. One had some idea, but through their own research. And I was digging. I was like, "Oh, how did you find out about that?" She's like, "Mrs. Google" was her key answer to that. She used Google to find out all of her information and didn't really get much engagement with the surgeon, which is interesting. And I think that was, yeah, so she didn't get much engagement with the surgeon. And then the other one had no idea about it at all, or why it would be important. And I mean, that was in the pre-phase. So I guess that's to be expected. And perhaps, as you said, it'd be interesting to go back and then interview patients now and see if they're getting exposed to the pathway, or if they have that understanding that they need to go and get their tests done.
That's super interesting, isn't it? About the, sorry, I'm asking a million questions here, Karen. I promise I'll stop talking now. But that's super interesting about the clinicians, the doctor, the surgeon not giving the advice, because they're going to be such strong opinion leaders for those patients, aren't they? So, I think this is a very interesting, thorny bit of work to be doing in there. Good luck, anyway. Thanks for the presentation. Really good.
And that's really interesting. And on that note, do you think there is issues around, you know, health literacy and also, you know, cultural diversity and, you know, that communication, you know, effective communication between everybody, that might be an issue too? Definitely,
especially in the public setting. I think if we consider the different socio-demographics that might attend a public setting as opposed to a private, I think that's definitely something that would be worth considering. So something we would probably do to be inclusive is to make sure that that information is available in different languages. Ultimately, my dream would be to have an optimization app, and then we can somehow, you know, have like a checklist of what patients need to do and like a little bit of information about why we want them to do that. That's my pipeline dream down the track, and to go beyond just anemia and iron optimization, but also look at things like diabetes, making sure patients are, or trying to optimize their weight before surgery. So having an app to do that would be spectacular.
That's all sounds, that's great. Well, that's, you know, once you've finished your PhD and your child's running around, then you can add that into your schedule. Is there anybody else got any questions or any thoughts there for Alana? We're sort of drawing to a close soon, so if anybody's got anything to add? Well, I think from my perspective, it's been absolutely fantastic. It really has. You've done some really great work, and pulling all this together, and you've got the publications, and you're writing all that up. And I think what you identified, that there are some areas that these frameworks didn't address, and to put into your sort of discussions would be absolutely very interesting, and really really good to find out a bit more about that. But and good to know that you've got some excellent plans for when you're finished.
Yes. Too many.
Yeah.
Too many little pots.
And Alana had a video as well that I think we shared, didn't we, for everybody, if anybody wants to have a look at that.
Yeah, one of the challenges I think is explaining to both funders and clinicians, and as like everyone, trying to explain implementation science can be really tricky. And I felt that what I did here was quite complex and busy, and it might be hard for people to really understand what I've done at that clinician funder level. So I created a little cartoon video that kind of steps through really clearly and concisely what we did and why we did it. And I think that's something that we need to do more of in implementation science, is try and work on that communication piece. How do we take our lessons learned and communicate them really clearly to people at all different levels, to then encourage them more to come into the dark side of implementation science?
And I mean, from the chat, and I'm sure you can see that, some really excellent feedback, and some other people, Sarah mentioned about her changing sort of frameworks as well along the way. So, I think there's quite a few of us had that experience. So I really want to thank you, Alana, for a wonderful presentation. And Alana's just put up her YouTube video for anybody to have a look at as well. We've just, this is our last ISIG for the year, and we will be back in February, and we've got Professor Nick Goodwin coming to present to the group and join the discussions from the integrated care focus as well. So we look forward to seeing you all next year. Have a lovely, safe, festive Christmas period, and hope we can get the borders open and we can continue to sort of meet each other. Yeah, we'll look forward to seeing you all in February. But and thank you again, Alana, for a great presentation and a wonderful discussion.
Thanks, everyone. I really appreciated all your questions and comments. It was good to, we all love talking about our own research, don't we?
Thank you again. All right, take care, everybody. Thank you. Bye.